Good evening, everybody. My name is Dominic. Thanks so much for joining the webinar tonight. What I'm going to be talking about this evening is crestal sinus lift techniques, combining Ethos with densification burs. Just a disclaimer at the very beginning of the webinar tonight, I've got no financial links to Ethos Regeneration Limited, no financial links to Versa LLC, and again, no financial links to Implantium UK Limited. So I'm definitely not a key opinion leader for those who may be interested in that. Well, first thing to do is a quick introduction of me. Who am I? Been a dentist since 1993, so I'm an old boy. I qualified in Liverpool. Worked initially in the hospital and then progressed into general practice. I've been in general practice ever since, apart from a stint as being clinical director of a body corporate, previously working for Boots as a dentist as well. I've been doing implants for many years now. I'm very interested in full arch immediate loading, sinus lift techniques, bone grafting. I really enjoy aesthetic implant cases, and I've been using beta-tricalcium phosphate in its various iterations for years. Ethos is my go-to material. So I used to be a cyclist. I'm not anymore. Basically, I had a very bad accident last year, and my wife banned me from cycling anymore. She said if I did pick up the bike and go cycling again this year, I'd be living in the shed prior to a very speedy and rather painful, financially painful divorce. I'm a geek, a little bit autistic. In fact, I am actually diagnosed as high functioning autistic. I'm a family guy. Got 5 kids from the ages of 30 down to 12. Bit obsessed with dentistry. I love implant dentistry. I love implant surgery, and I tend to think perhaps a little bit too deeply about certain things. Perhaps I tend to be a deep thinker and find it difficult to switch off thinking sometimes. And that was one of my heroes there, Eddie Merckx, when he used to cycle. So tonight, let's think about what is my hypothesis. Is my hypothesis a nuclear bomb blowing it away, or is it actually nucleation? Is nucleation something that I'm interested in here? And am I thinking about how nucleation and how the formation of nidi of nucleation can improve bone formation when we're doing crestal sinus lifts? And I think that's the core of what I want to talk about tonight. Is it a nuclear bomb, or is it actually a damp squib? You know, let's be honest, people have been pushing particulates into the sinus for years. So why am I getting so fixated with this nucleation thing? Am I actually making a mountain out of a pile of mold droppings? Hey, who knows? So let's think a little bit more. What I'm really thinking about tonight, by combining these two techniques, by combining Ethos with densification, is to create 2 primary sources of nucleation. And are they going to be synergistic together? And there's also a secondary source of that's really important of nucleation as well, which is calcium sulfate. I'll go on to that in a little bit more detail later. So we're combining autogenous bone particles, the way that the densification process really sends the bone particles in both a lateral and a vertical direction, using the cushion of water around the Versadrill. And how that works by the anti-clockwise rotation of the Versadrill, this, I suppose, quasi-Archimedean principle as the material is pushed laterally and apically, and how that principle combines with the Ethos particles being placed in close association with these. And that's really how I'm trying to, my hypothesis is these 2 primary sources of nucleation to try and really enhance the process of bone formation, true host bone, beneath the Schneiderian membrane in the sinus. Just going off tonight's topic for a minute, I just had to put this in. I do a bit of mentoring. I love mentoring. It's one of the things I really enjoy. I was mentoring a fabulous dentist called Anna McDonough down in Bromsgrove at the weekend, and that's her there with two of her fantastic nurses. We did a variety of cases on the Saturday. One of the reasons I've put it in tonight is that one of the cases did combine densification and ethos in a very, very nice way. Before I go to that, I just wanted to share a couple of cool pics. She'll be very embarrassed, I'm sure, now that I'm doing this. But I think this is going off topic, but it's such a lovely photograph to show the ideal positioning of the palatal socket wall osteotomy for that central, upper right central implant placement. Rarely have I seen as good a photograph as that, showing that. What she's done as well is she's taken the implant off the upper left lateral incisor, placed a locks and carrier, and it's just assisting us with that guide for location with regard to your vertical location of your implant as well. So it's quite a neat little technique, to be honest with you. The teeth on either side have been extracted very atraumatically, and they're going to be ridge preserved. I'm absolutely furious when I say, well, I'm not. I'm a bit cross when I hear socket preservation, because the last thing we want to be doing is preserving the socket. But what we do want to do is try and predictably preserve the ridge. So this is what she's done. We've got the implant in place. She's put the crown back on the lateral, and she's placed Ethos into the two very well degranulated sockets. She's also placed Ethos into the jump gap, which is labial to the position of the implant. And I was really pleased. I thought it was a fabulous case, and a little bit in awe of her. She's got fantastic hands, super surgical technique. So going back on topic a little bit, we were looking at another case where we're initially considering upper right 4, 5, 6 with implant positioning at the upper right 4 and upper right 6, tissue level implants with a wide neck at the back, thinking about a crestal sinus lift at the upper right 6 position. The CT seemed to suggest that was going to be okay. When we got in there, I'm afraid the upper right 4 side, it was bone, kind of bone. It was this soft stuff. It appeared to be some granulation tissue mixed in with the bone. We both felt it wasn't an appropriate site for an implant, so we decided to do something a little bit different. And I think it's important when you're doing implants that you're aware that you may have all your planning already and you're ready to go, but when you open that flap, when you degranulate that bone, you may actually find that you have to amend your treatment, and it's important that you've got in your mind treatment alternatives. Obviously, the alternative we want to try and avoid is actually having to close the flap and not do the implants, and yet that sometimes is exactly the right thing to do. But anyway, going back to this, implant placements at the 5 and at the 6. Dents are used in both sites. However, at the 6 site, the denser was used to lift the sinus floor, and then Ethos was placed, and the denser was used again very slowly with no irrigation to place the Ethos into that crestal sinus lift prior to placing the implant. It's an important slide here that really shows us two things. It shows us a halo of bone only above the 5 implant. It shows us Ethos socket preserving this dehiscent socket defect for this early sort of placement here at the 4, and this really gorgeous halo of Ethos mixed with those autogenous bone particles for the 6 implant. Beautiful positioning, but you can see the difference. So you see the difference in appearance. You see this is bone particles forming a halo under the membrane. This is a combination of Ethos and bone particles forming a halo under the membrane. And I fully expect that to form new host bone. That's what we want. So nucleation, let's quickly go through this. Why is Ethos really good for this? Something to do with the negative zeta phase. Now, that's a high electrokinetic potential, and it's to do with colloidal systems. And I'm not going to try and blind you with science here, but a negative zeta phase is not unique to Ethos. Many particulate bone grafting materials have a negative zeta phase. However, Ethos has a high negative zeta phase, and this has effects with regard to osteoblasts and the calcium channels that are engaged in the osteoblasts involved in bone formation. These calcium currents in osteoblasts are potentiated by this zeta phase. The second thing is with Ethos is you do get fast and quasi-complete or complete resorption of the Ethos. It's very different than perhaps your bovine decalcified, deprotonated, bone sources, of which there are certain famous ones. They're not decalcified, obviously, they're deprotonated, where one of the things that you do find is that even at 10 years, there's a significant proportion of that material left. Sometimes you may want that. Sometimes you may want that scaffolding. However, for me, my view is that if I can get host bone, that's what I prefer. Densification, so let's think about that. So we've got the reverse Archimedean screw principle. So it's sort of, what it's doing is it's really doing the opposite of an Archimedes screw, kinda. Forcing bone fragments on a cushion of water laterally and apically. It's also, and this is really important, it's destroying, crushing bone cells, and you're getting nano fragments of cell membranes from these bone cells, and these are in effect also acting as nucleation sites for the amorphous calcium phosphate. So you're getting your androgenous hydroxyapatite. You're getting your bone formation from that. So let's just go backwards a little bit and think about what are some of my previous techniques that I've used over the years. I've always enjoyed crestal sinus lifting for many years. I think it's a very, very useful technique. It's not a simple technique. It's a technique where the potential for negative outcomes is there. However, like any other implant placement, any other implant technique, proper planning, proper case selection, and being appropriately experienced, learning the techniques, practicing the techniques, being mentored in the techniques, allows you to be as predictable as possible with these things. For me, initially, I used to use a mallet, concave osteotomes, used to really enjoy that. I think I enjoyed it a lot more than the patients enjoyed it. You know, patients don't like having their heads malleted, particularly. You use a pull tap. It's a little bit, looks like a sort of a surgical version of a toffee hammer. You're basically not following through with each tap of the hammer. You're pull tapping, which is a gentle technique, supposedly. But patients do occasionally get negative outcomes from this. And these can include fairly serious outcomes, such as vertigo from movement of particles within the inner ear and within the vestibular canals in the inner ear. That's an unusual outcome, but it can happen. Other things that have been noted are things such as tinnitus, patients feeling sick, patients finding that they get highly apprehensive for the rest of the implant procedure because they're not really fully aware of how it feels to have a mallet used. So therefore, great technique, used it for years, enjoyed doing Summers lifts. There's a real pleasure you get from this kind of almost orthopedic in-fracturing. This type of dentistry is pleasurable for the surgeon, and it really works. As I say, that there are negatives. The other thing's the DASC, and I still think the DASC is an absolutely superb bit of kit. I tend to use it mainly for lateral window techniques now, either a single window or create two for a larger graft. The vast majority of times you can avoid perforating the Schneiderian membrane. Not all the time, but usually. I've used DASC quite a bit for crestal sinus lifting as well. However, for me, personally, I prefer VersaBurs. I prefer the densification way forward. And I think that's because it's, in my view, an additive technique. I'm using densification and creating those bone fragments, adding to my nucleation potential, which is what I've talked about repeatedly in this webinar. So, brief synopsis. Let's go through burs very briefly. What you're trying to do with densification, the denser burr system, is increasing bone density. This compaction autografting, now what is that? That's basically this grafting of bone fragments, bone particles, smashed bone cells, bone cell membranes, the rest of it, around the drill, around the lateral sides of the drill, and also apically to the drill. You're creating a springback effect, which is that you're actually getting a springback of the bone after you've removed the drill. We've talked about nucleation. You're really protecting the Schneiderian membrane, and you're doing that with a cushion of water. It's quite similar to DASC in that way, insofar as you've got a cushion of water between the end of the drill or the end of the tool and the membrane. And that's why it's really important when you use this technique that you make sure that you've got copious sterile saline irrigation, and it's a pumping technique. It's a newer technique, and therefore there's less long-term data, and it's got to be said. Other techniques have a lot more real long-term data. Looking at it compared to cutting, you know, we've done it for years. Cutting works really well, removes bone, tried and tested. It's got long-term evidence behind it. You usually under prep. Most commonly in the maxilla, you do under prep. Not always, but usually. If you're not careful, you may get some coronal compaction necrosis. So you've got to be careful when you do these cutting techniques. You've got to also be careful when you do densification techniques for that as well, but I'll talk about that in a bit more detail. One of the real issues with cutting is trauma to the Schneiderian membrane. For me, having trauma to the membrane really can, in some cases, preclude you going forward with the crestal sinus lift at that point. You're also in a difficult position with regard to, well, what do you do with that? Studies tend to suggest that small traumatic lacerations to the membrane heal very quickly. However, you've got to use your judgment, you've got to use your skill level, your experience to make those calls. But trauma is likely. I think particularly when you're using Lindemann drills, lance drills, sharp drills, trying to perforate or penetrate that cortical plate beneath the sinus, it's very easy to make a little error and just actually damage the sinus membrane. So densification, I think a paper I'd enjoy for you to read if you can, the Gluckman paper, Huey's Mazor Gluckman paper. It's a retrospective clinical study, 5-year follow-up. We're looking at really densification, sinus augmentation, and this compaction grafting. It's not true to say they're just using the autologous bone chips. They are actually using particulate bone. However, it isn't Ethos in this particular study. On the other side of the coin, compared to this paper, you do get Elsaid and Osman, and they've done a meta-analysis, and they suggest that further work's required with densification before it becomes part of routine practice. Now, for me, I'm satisfied that it works well in my hands, and I use it routinely. But I think you should be aware of both sides of that coin. So let's look a little bit at Ethos compared to a bovine particulate graft. I think these are two very commonly used grafting materials. Ethos, let's look at it first. It's an alloplast. I'm finding in my practice, particularly more and more, patients don't really want cow bone, and they don't really want human bone either. I've, you know, a lot of mineros grafting in the past, graft-on, and then bios, obviously, various different xenografts or human grafts, so allografts. And the thing is, patients tend to not want them. Some do, but many don't. The fact that it's an alloplast, it's made in a lab, it's fully resorbed, it's converted to true host bone over a period of time. This seems to be something that's appealing to my patients. I've got to be aware of the cognitive dissonance I might have in discussing the various techniques. I've got to be honest there. However, I am very, I think I always try to go back to, well, what would I have if I was having a bone graft? And it'd be, without doubt, an alloplast. I think it'd be extremely unlikely I'd have a xenograft or an allograft at this stage in my life. And I actually have got an alloplast in my wrist where I broke it last year in this crash I had. And it's beta tricalcium phosphate, and it's worked very well, but that's by the by. So thinking about Ethos again, a high negative zeta potential, I mentioned that before. I think if you're that sort of scientifically minded, have a look more into that. I think it's very interesting. You have a calcium sulfate initial scaffold with Ethos. This is particularly important. It also helps with nucleation. It helps form a pseudomembrane. So for those who are thinking about, do you need a membrane? You don't. The calcium sulfate sets in such a way that it forms a pseudomembrane. This nucleation potential is really high with Ethos. I think it's, I put a question mark here, osteoinductive. It is osteoinductive, and I'm going to go into that in more detail in a moment. It's a bacteriostatic product. That's not bactericidal, but it's bacteriostatic. Small exposure of Ethos tends to get epithelialized quickly and well. I've never had an infection with it, ever. It's technique sensitive. Any bone grafting technique is. And I think that in certain cases, such as the large lateral window sinus lift, there are reports that you can lose volume with it. But for me, would I rather a little bit less volume and have host bone, or would I rather a load of volume, but it's maybe not really bone, but some form of hybrid material that's scaffolded with some bovine material? Again, for me, I'd be thinking about an alloplast. So thinking about cow, so it's a xenograft, it's partially resorbed, and even at 10 years, studies suggest that there's a considerable proportion of this material left. And that's a double-sided coin, is that it's a long-term scaffold. However, there's a couple of anecdotal reports now coming of very late failures, infective failures of grafts that have been in the sinus for decades, for over a decade. It's also got a negative zeta potential, so there's that nucleation potential. It's osteoconductive. It's not been shown to be osteoinductive. It's not a bacteriostatic material, particularly. It's technique sensitive, like Ethos is. These late failures I alluded to, there's some anecdotal evidence that there are some of these coming through now. Whether that's backed up by formal scientific appropriate evidence at this stage, I don't think it is. But there is long-term data available for it. So osteoinduction, let's think about that. For me, again, scientifically minded, try and read some papers. Pamela Habib-Bovic, to be honest with you, I think she's a key researcher for this. Yeah, it's osteoinductive. Do your own further reading, but I'd suggest that she's a very good start point. I think if you can go on Google Scholar or PubMed, get some papers, read them, and I think you start to understand this extremely complex subject. But this almost, we could call it an intrinsic osteoinductive theory that seems to be the case. It's worth this paper. This Smeets paper is a good paper if you're thinking about zeta potential. Again, it's this biphasic osteoinductive calcium composite material looking at negative zeta potential for bone augmentation, and it's hyper academic. It's really an academic paper, but again, read it. Spend your time really getting the background on this subject. I think it's very, very important. This is the animal study from Pete Fairbairn, Minus Levetis. We're really looking at rabbit in this stage, experimental study. It's quite interesting, to say the least. And it really does provide the basis for further studies that have been done with human trophine studies. The rabbit study, if you look at the top left here of the screen, you'll see that there are small fragments of osteoinducted new bone here visible on the slide. This is in muscle. This is rabbit muscle. So we're finding new host bone forming here. This was something that I read today. Actually, I don't think I'd read it before, but Richard Myron. This is interesting. This is a really interesting paper. I know Pete's already put this on Facebook today. I strongly suggest reading this. It's a really challenging read. It's a long read. It's extremely interesting, but it's one of those where you have to get into the paper and have a real good read of it. But it's so interesting to really another view with regard to intrinsic osteoinduction theory. And I think it really supports the work that Pete's been doing and the view that the Ethos and beta tricalcium phosphate, as long as it has that specific surface characterization, is an osteoinductive material. So combined effects of Ethos and densification. Are we looking at Cheech and Chong here? We're looking at two washed up druggies bringing the drums to a gig, or are we actually looking at something a little bit more special? So what are we looking at? Well, for me, we're looking at something a little bit more special, to say the least. These things work well in my hands, I feel, and this is anecdotal evidence in my hands, that I'm getting enhanced formation of new bone when I use these techniques together. My current techniques, I think this is an important part of tonight's webinar. For me, I need to have 4 millimeters or more crestal bone. I need to have a healthy sinus. By that, I don't mean no visible sinus lining. I do cases where you've got some city sinus. So many people who live in urban environments have slightly thickened sinus membranes. That's different than having an unhealthy pathological sinus that's creating symptoms. I think it's appropriate to refer, but I think it's also appropriate to understand that there's a large proportion of patients have a slightly thickened sinus membrane. That doesn't preclude having sinus work done. Again, in my opinion, you need a patient who can open appropriately for crestal sinus lift. Your drills have got a certain height. There's no point trying to do it if you can't get them to open. They need to be consented properly for this. This is a DL consent process. It's them trying to understand these fairly advanced concepts, discussing it in layman's terms. I think it's really important when I'm doing this that I'm doing an appropriate flap design. I'm trying most often to do one relieving incision at most. I tend not to do bilateral relieving incisions at front mesially and distally. I think flap apposition is important here. I think it's important that the edges of the flap are away from the site of the crestal lift, unless I'm doing it, combining it with an immediate implant and extraction, which is even more technique sensitive. When I'm doing crestal sinus lifts using this technique, I'm nearly always doing this transmucosally. I'm placing an appropriate sized and shaped healing abutment, and I'm suturing the flap in such a way that it's nicely opposed around that healing abutment. It's routine, and I think de rigueur for this that you're using CT planning for it. You need to be able to see the sinus in 3D. You need to see if you've got certain things in your sinus that you don't want, such as grossly thickened linings, cystic change in the sinus, other more sinister pathology. You've got an unusual or irregular bony floor. And I think, for me, I don't use fully guided really, but I think a prosthetic guide is useful. Being able to see where you want your emergence of your implant. Usually try to go screw retained. I want my emergence to be appropriate for that within the prosthetic envelope, but also in the appropriate place on the tooth. Degranulation, I think that I can't overestimate how important this is. Degranulation of the site is vital. It's vital for placing implants full stop. I think it's vital if you're using any form of bone, allograft, alloplast, whatever. You need to be using degranulation either via sharp curettes, or ideally I'm using the degranulation burs, the Ethos degranulation burs, and they work very well in my hands. I tend to combine them with curettes. You need to have clean, bleeding bone. You need your bone to be lovely and denuded of all granulation tissue. Don't leave bits, tags of this, tags of that. it's not good technique. It'll possibly affect your outcomes. How do I enter the sinus? This is really important. It's so important that you've got an accurate measurement using your CT scan, and that you're using your initial pilot drill to about 1 millimetre beneath the sinus floor. I don't enter the sinus with my initial pilot drill. What I then do is I use versadrills, so the densification process, going up through the sizes, dependent on my final implant and how much reduction I want to do compared to that final implant diameter. A pumping technique. I'm using the versadrill anti-clockwise, obviously. I'm using it between 900 and 1200 RPM. I'm copious sterile saline irrigation, making sure that I've got that hood of saline above the top of the drill. And I'm actually entering the sinus carefully, with great care, with a guide finger, super care that you're not actually penetrating the sinus in an uncontrolled way. And then just 1 millimetre or 2, and using the marks on the drill, on the versadrills, to actually allow me to know exactly how far into the sinus are going. Up to about a 3 millimetre versadrill size, where when I'm at 3 millimetres, I'm at the maximum amount of lift that I want to do. And when I'm doing these lifts, I'm going 4 or 5 millimetres max. I'm not 6, perhaps. I'm not going higher than that. If I feel I need to go higher than that, my own personal technique is I tend to do a lateral window. I'd also be doing a lateral window if I've got less than 4 millimetres bone. I'd have a debate. 2 1 millimetre, it's going to be a lateral window. Try to place at the same time. If I feel I can't, then it's going to be a 2-stage technique. So how do I mix the Ethos? It's important to understand that it shouldn't be super, super dry. When I'm using Ethos for this technique, it should be not a wet mix, not a dry mix. It's a Goldilocks mix. It's somewhere in between. It's just right. It's some moisture still in it. You don't want it to be totally dried and completely desiccated of moisture. What I do is, once I've created that lift, may use the Valsalva maneuver, or may just use a round-ended probe to just make sure that I haven't got penetration of the lining, which I've never had. I then actually place the Ethos into the osteotomy, about 0.25 cc. Use the versadrill, still counterclockwise with no irrigation, at between 25 and 50 RPM, often closer to 25, pushing the Ethos into the crestal lift. Doing that a couple of times, 2 or 3 times, then placing the implant after the final load of Ethos has been placed into the osteotomy, using the implant to then place that final Ethos load into the crestal lift. Careful flap closure, tension free as always, apposition of the flap, trying to get primary healing, trying to keep the margins of the flap well away from the site of surgery if I can, using PTFE sutures often, usually, very clean monofilament type suture that works well in my hands. Technique sensitive, again, you need to do a modified surgeon's knot. You need to cut them in such a way that you don't leave them too short. You don't want them undoing. Teflon, PTFE, it's very slippy, so therefore you'll tend not to get ingress of bacteria into your wound. I think that's important when you're doing any grafting technique. The second thing is, being so slippy, I think you have to be a little bit careful when you're actually putting it in, putting those sutures in, that you turn them off properly. So for me, why 4 millimeters minimum? I'm not Istvan Urban. I wish I was. This is a good study to read. He went below 4 millimeters for his crestal lifting, and I'm aware of some people doing it at 1 millimeter. And to be honest with you, that doesn't float my boat. But you know, if you can show me predictable long-term results with that, then fair play to you. But for me, it doesn't work for me, and I think it's something I'm not doing. So let's have a look at a case. Planning first. So we're looking on the upper right side. this case, doing some measurements with our CT scan. We've got more than 4 millimeters here at this distal site. What's the key features of this case? The flap. I think it's important to understand that I've done a distal release behind that distal tooth in the molar. There's no mesial release. It's just around that canine. We're looking at the bony ridge, a bit irregular, it's nice chunky ridge. What we can see there is there's granulation tissue, particularly mesially on that ridge. It needs degranulation. You need to do that. Don't just prat around doing a tiny bit of degranulation and think you've done it. Degranulate, degranulate, and degranulate again. Make sure you've got rid of all that granulation tissue. Implants don't like it. Guided bone regeneration doesn't like it. Your results won't like it, so get rid of it. Implant position, you need to be, in this case, we need to be looking very carefully where we place the implants. We need to be aware of the angulation of the existing teeth as well, because we've got a slight difference in angulation between that molar and between the canine, and that's comparable with the lower jaw, and we need to be thinking about how our implants emerge with regard to that. So degranulation and then denser, clean bone, trying to get optimal implant position for the screw retain solution, trying at the same time also to get appropriate 3D location of my implant screw channels as well. So it's not just that I've got implants in the right place, but I've got the right place to get the screw channels in the right place. And, you know, at the end of the day, try to do everything in the right place if you can. You can see this picture, I think, illustrates slightly better than the previous ones about that angulation thing I was talking about. You've so many different angles to think about here. We're looking at tissue level implants again. No, sorry, we're looking at bone level implants, but we're looking at two different angles here. We're looking at the angle more towards the canine on the anterior implant. The posterior implant, we're looking more towards the angulation of the molar. We're looking at the two different techniques. We're looking at densification, purely the anterior implant, and we're looking at the Ethos and densification, the posterior implant, with a crestal sinus lift. And here we see this quite clearly. We've, again, thinking back to Anna's case that I cheekily included in my presentation. I'm sure she's going to give me a clip around the ear later for that. But just looking at that again, let's look again and remind ourselves, we've got that halo of bone from the purely densification procedure anteriorly, and then posteriorly here we've got that a different appearance, slightly more bulky appearance of the Ethos combined with those autogenous bone fragments at the posterior site. Pleasing position on the implants to allow an appropriate screw retain solution. In this case, there'll be two non-splintered individual crowns. You know. So that's at 6 weeks. So we'll go back there. That's time of placement. This is at 6 weeks. We've already got kind of a change in appearance of that Ethos there, changing and becoming more incorporated with the rest of the bone there. And what I expect to see with this case is that the sinus floor, once the cortical plate regains its full outline, will be there up here in a predictable way. So I think it's already converting there well at 6 weeks post placement. So let's have a little look at another case. This is a case for your, I think for your more experienced person. You need to have done some crestal sinus lifts in various locations before you start thinking of a second molar in this particular sort of case. It's a challenging case. Slightly thickened lining here again. It's not a problem. The patient's fitting well, no symptoms of any sinus pathology. We've got less bone here. We've got bone that's receding gradually towards the back. Wanted to place a tissue level implant here. Again, it's one of those situations where we choose our flap design very carefully. Initial flap, degranulate, degranulate, degranulate. Densification protocol, and then we place Ethos using the slow counterclockwise rotation of the denser drill. The drill that's just your final drill, so it fits snugly into your osteotomy. Counterclockwise, 25 to 50 RPM, 25, I would suggest. Placing Ethos into that crestal lift, then your final lug of Ethos, place it with your implant. So choosing my flap design here, sorry for this photograph, it's using a mirror. Looking at the flap design again, the mesial part of the flap, I've not done a relieving incision there. Distal I have. A lot of degranulation required again. Feeling the cortical plate of the sinus floor, so getting to that millimetre from the sinus floor. For goodness sake, don't pierce it with your Lindemann drill, your Lance drill. Don't do that. It's so important if you're going to do this technique that you do not go through that sinus lining as you start the procedure. You might as well forget it. Use your denser drill counterclockwise, 900 to 1200. You know, you could go reduce that as well, 450, 500, 600, whatever. But when you're doing this, make sure that you're using the pumping motion, copious sterile saline irrigation to lift that sinus membrane, to go through that cortical plate. Great care, using your hand, your guide hand, to stop that drill and keep it in the right place. It's important. Tissue levels being placed there, PTFE sutures, Ethos has been placed. 50 RPM I've used there. You should see spring back when you're placing your Ethos. So when you're placing your Ethos before you put your implant in, when you place the Ethos into the osteotomy, you should see it come down a little bit again. That suggests that you've got another suggestion that you've got an intact cnidarian membrane, which you take, and you do tend to see that. Pushing your final bit of Ethos using your implant. PTFE sutures I use, by all means, any monofilament suture, Proline. Been aware of the fact that if you're using Proline 4.0, it can be quite irritating to your patients. 5.0 less so. And your tension-free closure is so important. And here again, you see you've got a nice lift. We've got quite a bigger lift here. Could have used a wide neck implant here if I was worried. Wide neck tissue level could be used if you feel you haven't got primary stability too good and you're worried about when that, over that first 2 to 3 weeks, when you're losing some primary stability, whether you're going to have a problem with that implant, or a patient who you think is going to chew on that implant if you're going transmucosal. So this is for various reasons, is an advanced technique. Bigger lift, more difficult sinus floor, more difficult ridge, more difficult position in the mouth. For me, it's not your first case, definitely not. This case, a quick case here, this is a bit deceptive. This is a minimal case. So this is one of those cases where I could have probably not used any Ethos maybe, but I decided to use it and I got a really good result. The sinus floor is not flat here and I didn't need a big lift. What I used here was a BLT again, so it's a bone level tapered type implant. It's a minimal partial lift really, so it's not the entire width of the implant that I've lifted, it's just a tiny lift really, due to the sinus floor being at an angle. There's only 0.2 cc of Ethos has been used here, and then I've used the rest of that in the jump cap. So you have to be aware of your initial Ethos mix, so that, and also in your timing, that you're not just mixing it and spending 10 minutes faffing around, and then you find that you set your Ethos and you're having to open something else. Here we go. See that we've got on the day of placement, we've got that little Ethos lift that's on the right side of the slide, part of the, just at the edge of the implant. And then after the implant's been restored, I think it's about 14 weeks, you've got that nicely reformed cortical plate on the sinus floor. Nice lab work from Phil Reddington here at BDT Lab, which is in Adel. Thought I'd put a plug in for him. He's an exceptional technician, to say the least. So final case, 2 implants. The mesial site's just denser, the distal site's an earlier placement. It's a crestal lift with denser and Ethos. Again, importance of careful planning. You can see you've got fenestrations before the tooth came out here. This is the case, it's the usual technique, the back implant, the bigger implant. We've used that pumping technique with the densitrals, and then we've used the slow anti-clockwise densification drill to place Ethos into the crestal lift site, place the implant with the final plug of Ethos. You'll see at the base of the implant, the coronal section, that we've also used it in the coronal portion of the implant. We've got good positions, we've got a good impression, we've got really good tissue. One of the things I've seen anecdotally with Ethos is they're getting improved keratinized tissue. I think further studies need to be done on that. And then here we see the restored case with a new sinus flow there and a really nice Ethos lift. So, well, thank you very much, and I look forward now to taking some of your questions.
All right, thank you very much, Dominic. So we're going to go through some questions now. There should be a question mark on your screen, either at the top or up on the right of your screen. If you've got any questions, just type them in there. They'll come up on here, and we'll ask Dominic some questions. So far, we've got up a few questions. So thank you to Raoul. He's asked if you use it in a lateral window technique. Do you use a collagen membrane over the window?
I tend not to. I tend to use Ethos up to the edge of the lateral window, use that pseudo membrane to create that, and that works well for me. I believe others do use like Sinus fleece or collagen membrane. However, if I can avoid a membrane, I tend to avoid it. So for me, I tend to avoid a membrane. Thanks very much for your question. And as I say, I think the pseudo membrane formation from Ethos is advantageous with regard to new bone formation. Again, that's my feeling.
Yeah, thank you. And then a question from Mohammed. If it's fully absorbed, presumably it comes radiolucent. So what is the timescale do you notice the new bone growth?
Well, even at 4 months, you've got considerable new bone formation. You tend to find that you're getting calcified host bone material formed as the Ethos resorbs. There's two phases. Well, there's more than two phases, but there's two. Let's be simplistic. Calcium sulfate goes, and you tend to get this early increase in slight increase in radiolucency that you see as the calcium sulfate goes. And then you get an increase in radiolucency again as the new host bone forms around the Ethos granules of beta tricalcium phosphate. So therefore, what you're seeing there is you're seeing that a fairly early slight increase in radiotranslucency, followed by an increase in radio opacity again as the new host bone forms. I would suggest to you that you're in excess of 95% new host bone at 12 months. Perhaps a little less than that, it depends on the case. And that's something that Pete will go into detail about with his Trefine studies.
So I've got another question here from Michael. If we somehow can't get full closure, is that okay with Ethos?
Well, this is something that I'm a little bit controversial about. I use Ethos a lot for immediate placements. Placing Ethos into the jump gap, using appropriate horizontal mattress sutures and various suture techniques to cinch the socket together as much as possible around the healing abutment. However, I'll sometimes have a little bit of Ethos exposed. What many dentists do is use a Sinus fleece or some form of cytoplast membrane, other forms of membrane, to cover that Ethos, penetrate it with the healing abutment and place the healing abutment. So perforate the membrane and then place the healing abutment, suture that over the socket. What I tend to do is I've tended to not do that, and I've got epithelialization of that little bit of Ethos fairly early doors, quite early in the procedure, in the post-operative period, sorry. Interestingly, I haven't had a case where that hasn't worked well for me, and that is both in gravity affected situations in the upper jaw where patients are walking about, anterior upper cases, and also posterior mandible cases where you haven't got gravity against you, but you perhaps have tongue movements and the rest of it. And I'm happy to perhaps in the future share some cases with you about that.
Yeah, brilliant. So one last question. I've got a few people coming in with the same kind of question here. So from Alec, the degranulation burs, yes. What speed do you run them at? And is it with or without water?
I use them with water, and I tend to use them around 700 RPM. And it depends what I'm doing. You can use them a lot faster than that. You can use them up to 1500 RPM. I think that I have a little bit more control, lower RPM. And it depends. They tend to come in four sizes. For me, I tend to use the biggest and the second biggest, sometimes the third biggest. I think it's important that you spend time doing that. And it's important that you understand that sometimes I think it's also appropriate to use them and also use your curettes, go back to them, use your curettes. Make sure that your end result is that you've degranulated thoroughly. It's a technique like anything else. I think it's important to use a sweeping motion, not to be putting excessive vertical pressure on these drills. They're not an aggressive drill, but they've got an unusual texture, and therefore it's important that you don't use them in the incorrect way. So a sweeping motion, degranulating without taking shed loads of bone away.
Brilliant. Well, we've got lots of questions here, but we'll probably be here all night if we go through them all. So I'm going to pass these on to Dominic later. We can go back via email to the other questions. But yeah, thank you very much for listening. Thank you, Dominic, for giving us a great webinar.
Well, thanks very much. I enjoyed giving the webinar very much.
Brilliant, brilliant. And we will be putting a recording together so you can watch it again if you'd like, and we'll send that out via email. So yeah, thank you very much.
Thank you.